Dr. Winkler, we would like to speak with you about the updated position paper by the Austrian Stroke Society, particularly about the evidence-based treatment guidelines covering neurorehabilitation in general, and specifically about the inclusion of pharmacological compounds.
Well, in today's world, evidence-based guidelines and treatment recommendations published by national or international medical societies for a specific group of patients have become an important standard of good clinical practice. In the field of acute medicine, guidelines have a much longer tradition, but in recent years we can observe the increasing emergence of treatment recommendations also in the fields of neurorehabilitation. This may also be due to the more methodological challenges one is faced with rehab issues. These recommendations now allow clinicians to make more rational decisions based on more robust data and studies, providing more evidence on which interventions have a strong or medium evidence, are cost-effective and safe, and which interventions should not be used at a certain time point in routine treatment. Solid recommendations, and I mean at last a class 2 and above recommendation, also make it easier to propose innovative treatment interventions to patients and caregivers.
Is it common that a stroke society publishes neurorehabilitation guidelines?
Austria is certainly one of the most advanced countries worldwide in stroke care. It has a high-density network of stroke units and more than 22 neurological rehabilitation centers nationwide. Over 20% thrombolysis and rapidly increasing thrombectomy rates. For Austrian stroke specialists, rehabilitation starts during the phase of acute care as early as on the stroke unit, and knowledge about evidence-based treatment options ultimately leads to better long-term outcome. There's a clear rationale to assess the current available evidence and to make clear recommendations based on this evidence. The Austrian Stroke Society uses European Federation of Neurological Societies criteria, it's today's European Association of Neurological Societies, for the assessment of the evidence, which are very familiar for European and international physicians and which are followed usually very strictly.
As a clinician in charge of Austria's largest neurorehabilitation center focusing on past stroke care, what are the most innovative and important passages in this publication?
In my opinion, it is a true milestone for a stroke society to break so clearly with the traditional view that rehab starts after acute care and to clearly mention that neurobiological processes like neuroprotection and neurorecovery are essential for optimal treatment results in evidence-based medicine today, especially in the context of pharmacological agents. The armamentarium in stroke medicine, in acute as well as in rehab departments, is still very limited, and it is therefore of importance to see that neurorecovery enhancers were included into this publication and evaluated with a high recommendation level. Pharmacologically induced neurorepair strategies becomes increasingly a widely accepted treatment concept.
I guess you're hinting at SSRIs or cerebrolysin. What makes especially cerebrolysin so remarkable?
Let me speak to you about SSRIs first. When the FLAME study, the fluoxetine in motor recovery study, was published in 2011, we all had high hopes that fluoxetine and similar compounds not only alleviate symptoms in post-stroke depression, but also support motor recovery. Unfortunately, the latest studies, like the TALOS trial from 2017 with paroxetine, couldn't confirm earlier results. Today, we still cannot recommend SSRIs on a regular basis. On the other hand, in the recently published CARS study with cerebrolysin, motor recovery significantly improved about 88% in long-term outcome, and the ensuing CARS meta-analysis, including over 400 patients, confirmed these initial results. I have therefore shifted the focus of my treatment research more strongly onto cerebrolysin and its possible beneficial effects in improving the outcomes in stroke rehabilitation.
The recommendation level for cerebrolysin in the Austrian guidelines is Class 2, Level B. What exactly does this mean in relation to other pharmacological agents or widely established treatment methods?
Okay, let me quote directly from the guidelines to answer your question. The introductory text for the paragraph medication mentions that in certain cases medical measures can be helpful and improve neural repair. To a certain extent, there is a positive evidence for L-DOPA and antidepressants like the SSRIs. They are regarded as Class 2 to 3 Level BC evidence. Cerebrolysin, on the contrary, by the way, the only brand mentioned by the name, including the 30 ml daily dosage recommendation, demonstrated positive efficacy in rehabilitation, especially in upper motor extremity after stroke. And cerebrolysin is provided a Class 2 Level B evidence. This labels cerebrolysin clearly as the strongest in evidence among pharmacological compounds, comparable to evidence levels in aphasia, rehabilitation, or in dysphagia, both assessed with Class 2 Level B as well.
At the end, let me ask you about your research activities and experiences with cerebrolysin.
We have recently developed 2 different treatment concepts in stroke care in my clinic. First, patients being transferred to our clinic for the first time, normally within the first 21 to 30 days after their stroke, we follow the recommendations as they were published in the guidelines by providing 30 ml of cerebrolysin daily for 3 weeks, in combination, of course, with rehab therapy. However, for severely affected patients who need, for example, a second rehabilitation cycle and who are considered more chronic stroke patients, symptoms will persist after 8 weeks and longer. So we have begun to research on a combination therapy combining cerebrolysin with transcranial direct current stimulation. So far, with good results. We can improve motor outcome about 3 to 4-fold by applying this combination therapy. We have just presented first results of our new treatment strategy at the World Stroke Congress in Montreal, and we are currently planning to start a much larger multi-center randomized controlled trial in early 2019.
Dr. Winkler, thank you very much for this interesting interview.
You're welcome.